I'd like to thank you all for attending tonight's Health Science Entrepreneurs Annual Spring Event. My name is Jack Reynolds. I'm Dean of the School of Pharmacy in the Bouvet College of Health Sciences, and I'm thrilled to be here tonight with you at the Entrepreneurial Evolution Healthcare 2000 to 2020, looking way ahead. I look forward to hearing from this distinguished panel, who will assemble in just a minute. And I want to thank the Health Science Entrepreneurs Committee members, Joe Fleming, Chris Ford, and Carla Bell for their work in putting this event together this evening. And if it's like any of our past Health Science Entrepreneur events, it's going to be a great evening, great attendance, and I think you're in for a wonderful evening. Terry Fulmer, our new Dean of the Bouvet College of Health Sciences, could not be with us tonight in person, but will be here in just a minute via video to talk a little bit about our Health Science Entrepreneurs program, to give you greetings. Once again, thank you very much for coming tonight, and enjoy the program.
So welcome to all of our Health Science Entrepreneur faculty, alumni, students. This is a really special event, and I want to congratulate all of you as you come into the meeting and tell you how sorry I am that I'm not there. I'm in Seattle at our new regional campus, and I know that all of you can understand how important that is as we continue with our entrepreneurial activity at Northeastern. So please know I share your love of the Health Science Entrepreneur Program and that I think this is a really exciting event. I would say that as I've listened since joining Bouvet and Northeastern, not only have I learned a great deal, but I know that all that you're doing is making our college better, and you're making me a better dean. So thanks for what you're doing. Have a great meeting. And now let's hear from some of our superstars. Thank you.
Health Science Entrepreneur is there to lead you. They have so many members, their alumni, that successfully done the accomplishments that we want to see ourselves doing. And I think it's great that we are connecting to them and working with them to make us as the next generation of people to be innovative and successful entrepreneurs.
And we have entrepreneurs who have perhaps become retired and they have time for us. We have entrepreneurs in the middle of very busy careers who make time for us in different ways.
I feel really lucky to be a part of the HSE program because I've met mentors that are, first of all, serve as inspiration, and they've also provide insight into the world as it is now. You read about it, you learn it in class, but you kind of talk to one of the mentors, like, oh, this is a different perspective on the same issue, and you kind of get a more well-rounded picture.
I've sat through a number of mentoring sessions, and it's amazing to see the chemistry that develops between the mentor and the entrepreneur. And perhaps what may have taken months or even years to develop happens very, very quickly.
It's so exciting to be an entrepreneur in the health science area these days because of all the change. As we know, the costs are dramatically increasing. There's an aging population, and there's tremendous technology that's available from other disciplines that now can be applied. So it's very exciting because of the dynamics in the marketplace today.
Another mentor I met is Christina Chima, and she and I had a meeting at a Starbucks one day, and we actually ended up closing the Starbucks because we were talking for so long. And she gave me so much knowledge because she was in venturing, and she explained to me what are reliable degrees and what should I develop as a skill set to get myself more set in place in the entrepreneurial field of health sciences.
Being a mentor in this program is part of what we call the giving back. And as I mentioned earlier, it's very rewarding because the feedback you get from students. I expected it to be a positive process where I give a lot, and for a very good reason, because I look back on my professional career and I've had mentors with tremendous impact. What I didn't expect is to grow so much personally through the interactions with both the people we mentor, both students and alumni, but also with my colleague mentors that I'm interacting with in the process.
Well, I think Pam is a solo practitioner right now who has a lot of good skills that she needs to translate into a bigger operation.
Chris was a great
Again, he was a great sounding board. He had mentorship qualities in that he was compassionate, but he also didn't hesitate to encourage me to move forward, to push me.
The program taught me that as far as business goes, customers are key. They're the single most important measure of validation of the business. And we're really happy that we have our first customer that values our product.
Working on a venture it takes a certain personality to think it's fun, because there are major ups and downs. You know, anybody who's been through it will tell you that you'll take a radical swing from elation to depression, because that's just the way the world looks to a venture. And but if you're the kind of person who can ride that roller coaster, it's a fun ride.
The mentors are Northeastern alum who have come back to help out, but we also have friends of the university and faculty members. And this is not just a Bouvet program. We have folks from the College of Business Administration, College of Engineering, Computer Science. So this is, although it's a health science related program, it cuts across all disciplines.
I think entrepreneurs need to be self-driven, get up every day with a goal in mind. I think they also need to have a skill set. I mean, you have to have something you're building off of. I always have advised people, particularly students who are looking where to go, get out and get established, get some kind of a skill set that you can build off of, have a passion and follow it.
It's very rewarding to be a mentor in this program. There's tremendous value to just watch these ideas grow and create jobs and improve the economy, improve healthcare, and improve lives of patients. So it's just a wonderful opportunity, and I recommend it to anyone.
We think the Health Science Entrepreneur Program will continue on a very exciting growth path. And we think that's so because the word is getting out. We know that our entrepreneurs are saying, hey, I can add value, and they're excited about it.
Well, I want to begin the program. First of all, my notes to myself right now says, thank you, Jack, because I thought Jack was going to come up and introduce me. But I'm my name is Chris Ford, and I'm the chairman and co-founder of a company called American Renal Associates, which is a nationwide healthcare provider based in Beverly, Mass. Before I get going, I just want to say that video will be coming to a theater near you soon, so please attend it. But and all kidding aside, I want to thank the folks from the Department of Communication Studies at Northeastern who helped us put that video together, in particular Bill Lancaster and Brian Dixon. And Brian's here. Raise your hand, Brian. All right. Good job. But I'm a 1973 graduate of the College of Business Administration, where I turned my co-op job into a lifelong career. And that was in the outpatient dialysis market, and I have been forever thankful for the university and the background that I received here. And that's why I joined the Health Sciences Entrepreneur Program. I want to welcome everybody here tonight. We have a very sizable audience, and the event is entitled Entrepreneurial Evolution of Healthcare 2000 to 2020. And some people might call it a revolution rather than an evolution. And those of us that have been around the healthcare environment for many years realize that change of this kind of magnitude translates into opportunities for entrepreneurs. So we hope tonight you'll get some benefit from our panelists about where they see the healthcare system, where it has been and where it is going. But before we start with the panelists and my introduction to them, let me just go through the health science objectives. The program, as has been described, is university-wide. We sponsor healthcare events. We build a network for the mentors, the ventures, and the entrepreneurs. The only rule of the mentoring program is that you need to be an alumnus of the university or on the founding team of a venture, being an alumnus of Northeastern. We've implemented the mentoring program to try to take some of the alumni that's out there after graduation that have good ideas, want to start a business in health sciences, and to the support of alumni and friends and entrepreneurs, we try to bring that idea forward. So let me, excuse me, let me introduce our panelists, which includes 3 prominent healthcare professionals at the cutting edge of the evolving healthcare system. And first, I'd like to introduce Kristen Madison. Raise your hand, Kristen, who is the professor of law and health sciences at Northeastern. She joined Northeastern in 2011. She has an undergraduate degree in the University of California at Berkeley, a JD from Yale Law School. She also was on the faculty of the University of Pennsylvania in 2001, and she's very published in the health area. The second distinguished speaker is Dr. Joe Caveda, who is the founder and director for Connected Health, at Partners Healthcare. Joe is the founder of that center. He's well known for being an innovator in programs for leveraging information technology. He's internationally recognized in that area, and we look forward to hearing from him. The third panelist is Richard Anders. He's the founder of Mass Medical Angels and co-managing director of Reuben Anders Scientific. He holds a JD from Harvard Law School. He founded a company called Jurasoft, which was sold to LexisNexis. So there's a real entrepreneur that made it. He's a trustee of the Boston Museum of Science, and he's also on the Institutional Review Board at Dana-Farber. So the format for tonight is as follows. I will ask each panelist to come up individually and do a short introduction of themselves and their perspective on the healthcare system. Then when all 3 panelists have made that individual presentation, I'll invite them up to sit on the panel. Once they are seated on the panel, I'll ask a question or 2 to get the dialogue going. But then I would like to turn it over to the audience for participation. We like these events to be highly interactive. We encourage your involvement, and you can ask almost anything you want. The only thing I ask is that if you have a question, raise your hand and wait until the microphone comes to you. And then after the panelist session is over, the question and answers, my colleague, Dr. Kyle LaBelle, will come up. He will summarize the key takeaway points of the night so that we can all agree on what we heard tonight and what we learned. So with that, I want to introduce Kristen Madison.
Okay, thank you so much. So when I was first asked to talk at this event, I was asked to talk about the Affordable Care Act and its implications for entrepreneurs. And my first thought is I was absolutely the wrong person to ask to perform this function, because if I were the sort of person who would be good at spotting entrepreneurial opportunities, I would not be in academia, and certainly not in legal academia, where the articles I write have absolutely no hope of ever turning a profit. On the other hand, I think it does make perfect sense to ask a professor of law and health sciences to tackle this topic, because we spend a lot of time talking about changes in the healthcare industry and what their implications might be. And in my case, I talk about the implications for law and regulation. But it's clear to me that understanding something about the trends in the healthcare system and how the structure is changing is going to be important for anyone who is interested in engaging in innovation in healthcare delivery or in healthcare systems. And so my task tonight is just to offer a few thoughts about the nature of healthcare reform, starting with the Affordable Care Act. So that seems to be what most people today think about first when you say the words healthcare reform. They think about the official title is the Patient Protection and Affordable Care Act of 2010. I'll just call it the ACA. The core goal of the ACA is to expand coverage. And the reason for it is just that there's been a steady decline in the percentage of people with insurance. And so you can see that in this graph, which shows starts in 1999, goes the way through 2010, and you can see that the percentage of people who don't have insurance has increased from about 14% to about 16% at any time during the year. And you can see also where they're coming from. There's been a sharp decrease in the number of people, or the percentage of people with employer-sponsored health insurance. There has been some increase in government-sponsored insurance, but not enough to offset the loss. We know that people who have less insurance are less likely to have access or make use of medical services, and there's broad support for increasing access to healthcare services. And so what the ACA is intended to do, first and foremost, is to increase the level of healthcare coverage. And it does that in a lot of different ways. One of the most important ways that it expands coverage is by expanding Medicaid. And in particular, what it does is it extends Medicaid to everyone who's under 65 who has incomes of up to 133% of the poverty line. And in 2009, that translated to about $14,000. And so, yes, it's true that before the Affordable Care Act, there are people who are making less than $14,000 a year who did not have access to Medicaid in a number of states. The second thing that it did, and the thing that most people know, is that it imposes an individual mandate. It requires individuals, with some exceptions, to obtain some sort of insurance coverage as of 2014. The consequence for people of not having insurance coverage, say as of 2016, is a penalty, and at that year it'll reach 2.5% of your income, or I think it's, have it somewhere, it's the $695, whatever is higher. Right? So for a lot of people, that's going to be 2.5% of your income you'll have to pay as a penalty. The thing about that is that that's going to be somewhat of an incentive to get insurance, but it's significantly less costly to pay that penalty than to get employer-covered health insurance, which is running about $5,000 for an individual. And so we'll still have plenty of people without insurance, even with the penalty. One of the things that they're doing to make it easier to get insurance is there are a lot of regulations on insurance. One of the ones that's already in place that you may have heard about is that if you have coverage for your dependents, now dependents' children can stay on their parents' coverage until the age of 26. We've already started to see a decline in uninsurance and increased insurance among young people as a result of this requirement. Other sets of requirements are aimed at the insurance market generally, so now insurers can't turn you down under the Affordable Care Act if you apply to them. There are also limits on how they price insurance, so they can rate insurance according to age and whether you smoke, but they are not allowed to rate insurance based on your health status. And so that's going to make it easier for people who are sick to actually get insurance. So a few states have had requirements like this in the past, but this will be the first time that those requirements are in place nationwide. There will also be some regulation on the content of insurance policies to maintain minimum coverage for policies that are sold through exchanges. That's the other thing that's going to be a requirement of the statute, is that states offer exchanges where individuals and small groups can buy insurance. And so the major goal of these exchanges is to facilitate access to insurance, to make it easier for individuals to shop for insurance. So you can go to, say, a consumer portal where you can see what the choices are for you in your state. It's also meant to facilitate enrollment in insurance products and access to the subsidies that the government is going to provide. It's going to be very challenging technically to set up these exchanges and also politically, which is one of the reasons why at this point only about 13 states have actually created exchanges. A number of other states are doing this through orders of their governors, but many states have not actually gone forward to establish these exchanges. And if they don't have the exchanges in place in time, the federal government will have to set up these exchanges for them. There will be subsidies for low-income individuals to facilitate their purchase of insurance, and there will also be penalties for employers whose employees use the subsidized coverage on the exchanges. And again, this is an incentive to get employers to continue to offer coverage. So what does all this mean then for coverage nationwide? These are the latest projections that we have. And so we're going to have about 30 million people who gain insurance as a result of the ACA's requirements. They're split between people who will gain coverage through Medicaid and people who will gain coverage through products that are offered through the exchanges. You'll notice that employer coverage, they expect to continue to go down after the ACA goes into place, but the net result is that they expect more coverage. So this is, as I said, one of the central goals of the ACA, but it's not the only goal. So almost everything that I've talked about is found in two titles of the Affordable Care Act, Title I and Title II. There are 8 more titles to the Affordable Care Act. So let me just give you a sense of what some of these things do. So Title III is about improving quality and efficiency of care. So a lot of the sort of yearly annual provisions about how Medicaid is going to be changed were sort of shoved into this title, but it also does more than that. It expands quality reporting programs nationwide for healthcare providers. It changes payment mechanisms in order to encourage higher quality care. It establishes the Center for Medicare and Medicaid Innovation to implement and test new delivery reforms. It creates shared savings programs under which these entities called accountable care organizations will bring together different kinds of providers, and if they can coordinate care for Medicare beneficiaries in ways that saves money, then they get some payoff in return. And so that's meant to help improve costs and improve quality at the same time. Title IV is all about public health. It encourages preventive services and public programs in various ways. It mandates calorie labeling in chain restaurants nationwide. So that should be coming to you soon. It has provisions for studying the impact of employer wellness programs. And so there are lots of different provisions that are related to public health. Title V talks about expanding the healthcare workforce in various ways, something that is going to be important if 30 million more people have access to insurance. Title VI talks about transparency and program integrity. So this is the title that is going to require disclosure of physician financial interests in pharmaceutical companies and device companies. It strengthens the anti-fraud laws. It creates the Patient-Centered Outcomes Research Institute, which is going to lead efforts to engage in studies of comparative effectiveness for different kinds of treatments. Title VII creates a pathway for creating generic versions of biological drugs. Title VIII, the Class Act, was supposed to create a self-financing long-term care insurance program, but then they discovered that that was actually impossible under the constraints of the legislation, so it's not going to happen. Title IX imposes lots of different taxes, and Title X does a lot of other stuff. So there's a lot of things that are going on in the statute in addition to all the coverage provisions that everyone is talking about. Now, as you probably know, there's one little obstacle that stands in the way of all of this, and that is the United States Supreme Court. So I'll just spend a minute talking about the constitutional challenge to the Affordable Care Act. So the Supreme Court has been asked to answer 4 questions. The first one is the individual mandate unconstitutional? And I'm not going to go into the law on that, not the least of which because I'm not a constitutional lawyer. But so you understand the general idea that if it's unconstitutional, then it's not going to happen. The second question and related question that actually needs to be answered first is, does the Supreme Court have the jurisdiction to actually hear the challenge to the individual mandate? And this is because Congress can limit the jurisdiction of the Supreme Court sort of the bet is right now that they're going to say that they have the jurisdiction to answer this question. So this is probably not going to be the issue. The next big question is, if the court finds the mandate unconstitutional, exactly how much of the statute is going to be allowed to stand? A lot of times this isn't an issue, right? So if the question is a statute that's prohibiting flag burning unconstitutional, it's pretty clear if they say, oh, that's unconstitutional, then you just can't, have a statute prohibiting flag burning. This is a much more complicated statute than that. And so some of the choices that the court may face are, we can say that you can't mandate that people have insurance. They can say, you can't say that people you can't say that people have to have insurance, but we're also going to throw out the insurance regulations that require insurers to issue policies and to comply with the various rating provisions. That's actually what the government has argued, that if the Supreme Court strike down the mandate, then you should also strike down these insurance provisions. Meanwhile, the challengers have said, if you find the mandate unconstitutional, you should throw out the whole thing. So those menu labeling provisions, gone. The Center for Medicare Medicaid Innovation, gone. Everything in the statute ought to be gone if you declare that provision unconstitutional. So I've been reading a lot about what people think about whether this is unconstitutional. You probably have too. I have to say it's very hard to figure out what people really think, because part of what's going on is people are trying to sway the results of the opinion. My sense is that probably among lawyers, the people are leaning towards the idea that the Supreme Court will declare it unconstitutional, but I have to say there's a substantial minority that think that they may not actually go that far. The other question, though, in terms of how much will be struck down, this is a big question that I don't think that there's any sort of clear thinking on what might happen. On the one hand, striking down the whole thing will be incredibly disruptive, and maybe the court doesn't want to do that. On the other hand, trying to figure out sort of what is really at the core of the statute is very difficult, and so it's unclear what direction the court might go. The last question is a separate constitutional question about whether the Medicaid expansion is unconstitutional. I think the prevailing view among lawyers is that it is actually constitutional, but it also, if the court decides to strike down the entire statute, then they don't even have to discuss this question. So among lawyers, at least, there'll be a lot of interest to see what the court does with this provision. So I guess the next question is, what does all this mean? So what does it mean actually if they strike down the statute? I think that it means a few things. I mean, first, it means that there are going to be a lot fewer people who are insured, at least in the short term, and probably in the intermediate term as well. And that's going to mean less demand overall for health care. So that might have some implications for entrepreneurs. Striking down the act, particularly striking down the whole act, as I said, is going to create a lot of turmoil in Congress. Now, in theory, there's bipartisan support and industry support for a lot of these provisions, but you kind of know what Congress has been doing, and quite honestly, they haven't been able to come to agreement on much. And this is an election year, which is going to make agreement even more difficult, I think. And so it's unclear what will happen with them. In addition, if the whole act is struck down and Congress doesn't immediately resurrect these provisions, there's going to be a whole lot of litigation, because so many of these provisions have already been implemented. Everyone's going to be struggling to figure out what that means for their individual program and for reforms that they've already put in place, and for the money that's flowing to them. But I guess what I really want to say is that ultimately the Affordable Care Act is part of a much larger health care reform effort. And I've just picked up a few sort of random examples on this timeline. Our timeline in this event started in 2000. So, for example, I mentioned the Affordable Care Act has provisions having to do with quality reporting and payment reform. Well, in 2003, that's one of the first big provisions having to do with payment reform. So it started well before the ACA. It's going to continue well after the ACA, regardless of what happens to the ACA. States are doing things on health reform. So 2006, the Massachusetts healthcare reform. Massachusetts is still grappling with health reform, regardless of what happens with the ACA. A lot of what is happening in the ACA depends heavily on improvements in information technologies. Well, those were really bolstered a lot by a 2009 statute that gave out billions of dollars in incentives to healthcare providers to implement and improve their electronic health record systems. That is going to continue regardless of what happens to health reform. And so the general point is that this is just part of a larger trend, and so even if it is struck down, I think you'll see many of the reforms we're talking about still continue. And so I guess my bottom line is that in thinking about entrepreneurship, it's one way to think about it is to think about what the big challenges are in the long term and what kind of opportunities that might create. If the ACA survives, there's going to be a lot of work around trying to figure out how to structure and implement the ACA's institutions, things like exchanges. How to meet the greater demand for services. So figuring out ways we can expand the primary care workforce is going to be incredibly important. How to meet expanding IT needs. The exchanges depend really critically on expanding our IT capabilities. So do accountable care organizations in the way that they deliver care. So any products that help them do that, there's going to be a market for. And again, these things, people expect at least some of the exchanges to survive, even if the ACA is struck down. Accountable care organizations will probably survive in some form, even if the ACA is struck down. Coordination is a focus of the ACA and many other kinds of healthcare reforms. How to support patient involvement in care. There's a provision in the ACA that has to do with supporting patient decision aids, and it calls for certification of those aids. That's, again, something that has been a long time coming. People have long been interested in patient-centered care, and that interest in that will continue. How to promote better health behaviors is a critical question. And lastly, we all know this is coming, how we can figure out ways to limit costs and demonstrate value of the healthcare services and products that we create. And so I guess in conclusion, I'll just say there are tremendous challenges facing us in the healthcare system, regardless of what happens with the Affordable Care Act, but I think there will be many opportunities along the way. Thanks.
Thank you, Kristen. We'll eagerly await Chief Justice Roberts and the Supremes and figure out what they come up with here. Our next distinguished panelist is Dr. Joe Caveda, who is the founder and director of the Center of Connected Healthcare at Partners Healthcare. Joe.
Thanks very much. What a wonderful introduction to what I want to talk about, and I'm so pleased to hear your just very spot on the way you attacked the law and what's at stake and what isn't. I run into this all the time where people think that everything we're talking about gets thrown out, and ensuring everyone is an important piece of it. But I would just echo that everything I'm going to talk about, the snowball is rolling down the hill. And it has to do with the fact that healthcare providers are being paid differently. And now in Massachusetts, this is not news. Partners Healthcare, where I work, which is the delivery system that is anchored by the Brigham and the Mass General, we are now at risk with essentially all of our payers in the state. Let me just review that because it means so much. We used to be paid by throughput through our institutions. We're now paid by efficiency with which we deliver care. It's a sea change. And it actually opens up opportunities for innovation like no other thing that's happened in my career in healthcare. And so it's in that context that I'd tell you a little bit about our center. We're 40 or 45 people, depending on how you count. We live within information systems at Partners, and we're dedicated to this concept that care should move out of the office, out of the hospital, and become a direct function in the lives of patients. This is really, I think, it's fair to say, the only service left on the planet that you have to visit someone to get the service. And it turns out, I've been at this now 17 years, but the reason I got involved was because I stumbled upon this idea that, gee, if you allow us to think about separating doctor and patient in time and place, you can unlock all kinds of value. And we've learned a lot of things along the way, but that was the sort of starting point, was this idea that we really limit ourselves by insisting that the only way you get our service is to come see someone like me in a physical location at a specific time. It's the only service left like that. So we're dedicated to figuring out what's appropriate, how to do that. We're not here to say face-to-face visits with your doctor are going to go away. On the other hand, you don't have to do everything that way, surely. Things like a blood pressure check. Why do you go into your doctor for a blood pressure check when we can measure your blood pressure all day long in your home if we want to? So it's that sort of thinking. We use technologies, predominantly monitoring and communications technologies, to achieve this vision. And we've had good success. I'll share with you a couple of programs as examples of what we've done, including improved engagement, which is really big, improved doctor and patient satisfaction, and improved quality and outcomes. So that's what we're about. Basically, we see two fundamental value propositions emerging in this work. And I want to share some examples that explain what these mean. So for improved self-care, and I would just digress for a minute to emphasize improved self-care, because I think that is the opportunity, in my opinion, for us to get out of this cost morass that we're in, is to give patients more to do. It's really quite simple. You check yourself in at the airport, you pump your own gas, you do your travel arrangements online over a website, you draw money out of a machine. Those are all jobs that used to be handled by people. In healthcare, you see 5 people on the way to see your doctor, and they'll ask you to fill out the same form that you just filled out. The 60% of our labor costs in healthcare, 60% of our costs are in labor. The remainder of the economy has gotten 1.8% more efficient with labor in the last 10 years. Healthcare is 0.8% less efficient. So that's an opportunity for anyone in the audience who's interested in entrepreneurial activities, is how can we make that labor force more efficient? We certainly can't attack the tsunami of chronic illness coming our way by hiring more doctors and nurses. We just can't do that and attack the cost problem at the same time. We have to think differently about this. So we started out thinking about this idea of just-in-time care. That's how we get started. Wow, if I had data coming from a patient in the home and I was a doctor or a nurse, I could probably make a more informed decision about their care. That was the idea. And we stumbled upon this idea that if you give patients that same information, they start to take care of themselves. And it's a beautiful thing. They manage their illness, they understand better, you can teach them in the moment because they have data in front of them. They use feedback loops to measure their success in the same way a batter uses a batting average to measure success, and it really starts to work. So it looks like this. I'm going to show you 3 quick examples. They all involve this idea of feeding patients their own information. That's what we call a feedback loop. I'm going to measure something about you and share it with you in context. Could be your activity level if you want to be more active. Could be your blood pressure if you have hypertension, your blood glucose if you have diabetes. It varies according to the condition. So we're going to measure that and then share it with you in context. We're also going to allow your provider to look at that in a population view. And that way, if I'm a nurse sitting in front of my population of diabetics and I see these 3 people are all having high sugars at 6 p.m., I can reach into their lives and say, let's talk about what's going on at 3 p.m. that's making your sugar bump at 6. And that prevents high-cost care from happening. It keeps people out of the high-cost part of the system. So example 1 is heart failure. The technology is shown at the bottom of the slide here. It's a weight scale, blood pressure cuff, and a touchscreen device. The people who are in this program are what I love to call the greatest generation. They're your octogenarians, people who are World War II vets, a lot of them. And one of the reasons the program works so well is because they wear a badge of honor that they're going to be compliant. So you give them a task. Weigh yourself every day, touch the screen, take your blood pressure. And by the way, if we don't hear from them by 10 o'clock in the morning, they get a phone call from a nurse. I noticed you didn't weigh yourself today. What's up? And very quickly, they're on the bandwagon. And then the other time they might get a phone call is if their weight goes up a couple of pounds. Heart failure is about managing fluid and salt, and the way you can quickly assess whether someone's got more fluid on board is their weight will change. So if my weight's up 2 pounds and I have heart failure, that could mean 2 more pounds and I'm in the emergency room. So they'll call up and say, gee, Mrs. Jones, I noticed your weight is up. Did you eat something salty yesterday? And these patients start to feel this sentinel effect. They're being watched. They feel cared for. So it isn't a bad kind of a sentinel effect. But they also, again, wear that badge of honor that that nurse is not going to call them. And the result is a 50% decrease in readmissions, all cause and heart failure related. And speaking of payment reform, one of the first beachheads for payment reform is no more 30-day readmissions. Some of you may know this. So this is a tool that we can use to keep people healthy in their home, avoid getting them into the high-cost part of the system. And the happy news for us is that we're now all of a sudden incentivized to do it. So it's a nice story. The second one is blood pressure. So what's missing here is a little home hub. I apologize for that, but there's the cuff. We give these patients a little wireless hub. They can put it anywhere in their house. They can take their blood pressure anywhere in the house, and it just feeds over the cell network into our database where we display it for them in a similar manner that you see in this laptop here. And again, there's usually a nurse or a pharmacist in the practice managing a population of patients with high blood pressure who will look and maybe make a phone call once a week or see them in an office visit and say, let's go over your readings, how's your lifestyle change going, etc. Very powerful tool to lower blood pressure. And you can see 69% of these people achieve the lower blood pressure. And if you had high blood pressure or very high blood pressure, the worse off you were, the better your outcome. We had people who get a 25-point drop in their systolic pressure, which is a wonderful outcome. So again, it's this idea of feedback loops and then motivating people on top of it. And the final one, okay, so there's the little wireless doodad on the bottom of the slide. The final one is diabetes. Same concept, swap out the glucometer, swap out the blood pressure cuff for a glucometer, and same concept. I'm uploading my blood sugar twice a day, which is, by the way, something my doctor asked me to do anyway. First time in history we've been able to really check that. How many times do you think we ask patients to test and they don't test? We all know diabetics that don't test. I'm sure you all know diabetics that don't test. Now we can say, gee, I notice you're not testing. Call them up. Call them out on it, and it makes a huge difference. So that's very powerful. And then again, seeing trends. In this population of patients, we've seen a 1.5 percentage point drop in A1C. It's directly correlated with how involved they are in their care. The more they upload, the better their outcome. Really interesting stuff. First time we've ever been able to look at it that way. The group has less hyperglycemic events, less hypoglycemic events, generally better control, and again, lower cost care over time. So that's an example of 3 programs. We do a lot more. We have a lot of other things going, but I want to be mindful of the clock and just give you a taste of the kind of work that we do. We also do consulting work. We do corporate-sponsored research, product evaluations. We have programs where we can help people who are anywhere from a guy with or a lady with a deck of slides to a Fortune 50 company. And we're very, very pleased to work in the commercial sector because so much innovation is happening there that we wouldn't ordinarily catch as healthcare providers. So our organization really is what I call a fence organization. We certainly do academic stuff. We publish peer-reviewed papers. We implement programs within partners, but we also are very, very involved in the innovation economy here in Boston and healthcare as well. And we do our symposium once a year, which I would urge you all to attend. It's in the fall. We have very attractive rates for students and people who work for nonprofits. It's a 2-day event. This year, October 25 and 26, we'll be at the Park Plaza, and it's 2 days of immersion in this growing marketplace of connected health. This is how to get a hold of me, and I know we're going to have a dialogue, so we'll take questions later, but I thank you very much for your time.
Thank you, Joe. Interesting stuff. I read an article today that just likened the change in the healthcare system to that what's going on in the media entities, and whereas not unlike that people used to use newspapers for all different reasons and they get their information somewhere else, retail advertising has gone somewhere else, so they liken that to the hospitals, and the current delivery of care is going to change over time. Okay, our final panelist is Richard Anders, founder of Massachusetts Medical Angels and co-managing director of Reuben Anders Scientific. Richard?
Thank you all for coming. I really enjoyed both of those talks, especially, that's my slide. They told me I had to have a slide, so. You know, you're talking to somebody who thinks that the ACA is the Angel Capital Association. So that was very educational. I want to tell you first a story. There are a lot of entrepreneurs in the room, and I want to tell you the sort of entrepreneurial story of how I got to where I am, because I think it has some elements that sort of connect in an interesting way. Was a math major in college, went to law school. After law school, because I was a math major in college and not entirely interested in law, I started a software company selling software to lawyers. I was fortunate enough to be able to sell that in the late 1980s, and then embarked on a couple of publishing ventures. Published a guidebook to CD-ROM software right at the time that the internet was breaking. Very difficult proposition. And then a series of newspapers, and the old adage, the best way to make a small fortune is to start with a large one and go into the newspaper business, is certainly has elements of truth to it. That was a great business until the internet bubble crashed, because when the internet bubble crashed, all the advertising that we used to get in the newspapers evaporated, and we had multi-page ads that went unpaid, and it became very difficult to fund the printing of a newspaper, even in the internet age, when the people who were on the internet weren't able to pay you in cash dollars for what you needed. But also in the 90s, I got very interested in angel investing and was fortunate enough, because of my software experience and selling my company, to be able to do that. So I joined an angel group called Common Angels. And then a couple of years after Common Angels, I thought there was room for another angel group, maybe an even earlier stage angel group. So I started one called Launchpad, which I'm very proud to say is now the Angel Capital Association said it was one of the a handful of most active angel groups in the country in 2011. In the early 2000s, a friend, a very famous physicist who had as a graduate student a PhD candidate in physics, said to me, there's somebody who wants to talk to you because he has an idea, he wants to start a company doing due diligence for venture capitalists, and wants to talk to you since you have experience in investing. So I met with him, and over lunch I said, venture capitalists aren't going to pay you to do due diligence for investments. They are the cheapest people in the world. And as a result of that, he asked me if I would consult with him, and we eventually hit on the notion, again connecting the law and what I did, and connecting the investment side, my expertise and knowledge of investing. We hit on the idea of placing scientists as legal experts in patent litigations, which is my day job. Connects my love of science, connects my law degree, connects my angel investing. But I took a sabbatical in the middle of that and went to work for a venture capital firm. I'd always been interested in venture capital, and I got to spend about a year and a half at a venture firm. And I thought that was really interesting. And one of the things that was most interesting was it got me into life sciences. It was a small venture firm, basically one partner and me, two partners, but really one. It was his firm. And he asked what I wanted to invest in. I said, well, you know, I know the software industry, but I don't really want to invest in it. It's not the business that I grew up in. It's not as interesting. It's all enterprise-level software now, and I think all the really cool, good stuff is gone. I'd love to do internet. And he said, not on your life. I tried that in the early 2000s. This was about 2005. And I'm not going there again. You can't do that. So I said, all right, I'll do healthcare. And I knew nothing about healthcare. So I was very proud of myself. I like science, so I started to pick up some of the scientific jargon and some of the lingo. And because I was in the newspaper business, I wasn't afraid to ask questions. I had done some writing and reporting in the newspapers that I owned. I think something, I don't know, every time. Sorry, I apologize for this loud clicking. I don't know what to do about it. Just wipe it off when you hear it. I knew how to ask questions. I wasn't afraid to ask questions. So I learned a little bit about science. And when I did that, I thought, oh, okay, I really understand the healthcare business. Then I learned that there were these things called the regulatory side. And So I started to pay attention to the regulatory side, and I learned a phase 1 trial and a phase 2 trial and a phase 3 trial, and then I thought, okay, I'm really getting this stuff now. And then they started to talk to me about reimbursement. And it went on and on and on. And unfortunately for me, although I did find a couple of really interesting investments with a couple of them having sensational exits, I did not persuade my partner to invest in them because I was not good enough as an advocate at that stage to be able to do that. So it was an amazingly good education for me. May not have been the best investment for him, but it's what led me later to want to start Mass Medical Angels, because I look at the healthcare field and I see from 50,000 or 100,000 feet that it's crazy. It's incredibly difficult to get stuff out there. It's incredibly hard to bring a new product to market. Now, for those of us who spend a lot of time in the business, we know why that is. If we're down in the weeds, I mean, it's all weeds. It's the most complicated, Byzantine, tangled enterprise known to humankind, I think. I mean, I've been in a number of businesses. I know a lot of friends who've started a lot of businesses, and I think life science is incredibly complicated. It is an immensely hard business. I salute every one of you who has the nerve to try it, because it really is daunting. But at the same time, it's immensely rewarding. It's just a wonderful, wonderful business. And so I thought, what can I do to try to bring more things to market? How can we get more products to market? And I thought, well, I thought about starting nonprofits. I'd done that before, and I thought about some things like that. But ultimately, in speaking to people, it seemed like this is a great business for actually making money and at the same time doing good. Because if you can fund life science companies, and you can make money funding life science companies, you're doing exactly what you want to do anyway. You're getting more products to market. And so that's why I formed Mass Medical Angels 4 years ago. And it is, well, one of the only entirely life science-focused angel groups in the country, and the only life science-focused angel group in this area. There are several other angel groups, Launchpad and many others, but which fund life science companies, but we are really at the core. What we do is life science, and all of our people are really deeply devoted to life science. So I'm telling you this as an entrepreneur because I want you to see how all of the parts of my experience really connect together to form a coherent whole. Well, actually not. I actually want to tell you, I'm telling you all that because I want to tell you a little bit about the art of storytelling. You know, I set that up as a coherent whole. It's not a coherent whole. While I was doing that, I was just sort of meandering from thing to thing, things that I liked, things that I was interested in, things that I fell into. And somehow I can tell it retrospectively and it makes all the sense in the world, or at least it makes some sense. But while it was happening, it didn't make that kind of sense. So the sort of two lessons I give from that are, one is if you do things that you like, you'll have a fun time. And two, if you try to tie them together, you will somehow be able to get coherence from it. And there's one other lesson, which is when you are presenting business plans, the art of storytelling. There are three kinds of business plans that people present. There are business plans, which is the typical business plan, which I'll tell you by slide number 8, and when I say business plan, I mean PowerPoint deck, because that's what a business plan is to me. When I get to slide number 8, I don't know what the business is. That's, believe it or not, the typical business plan. Don't do those. The second kind of business plan is the workmanlike business plan. It goes through everything, and it tells the story, and you know, it's not the most interesting thing, but by slide number 1 or 2, and I can give you a formula for the workmanlike business plan, but by slide number 1 or 2, you know what the business is, and it takes you through the issues, and by the end of it, you know what the business does. And then there's the inspired business plan. And I don't know if I did a good job of giving you an inspired story, but I tried to give you a story. And an inspired business plan takes you through and makes you think that the whole thing is inevitable. It makes sense. It makes you want to read it. It poses a problem. I'll give you an example of a really inspired business plan. We didn't invest in the company. Maybe I shouldn't have told you that. The first slide was Dr. Murray wondered why, unlike all the other ligaments in the body, the ACL doesn't heal. Now, that is a fabulous first slide. Why is it a fabulous first slide? Because it does so many things simultaneously. First of all, it's a question. Everybody's interested in questions. You look at it as a question, you think about it. So you're already with the person because you're thinking about the question that they gave you. Sort of an interesting question, but obviously they solved it, right? I mean, they're not going to put the question up and then say, slide number 2, and we never figured that one out. So slide number, you know that they're going to solve the problem, and you know it's about the ACL, and you know it's about knees, and you know that they've solved the ACL problem, and they've done it because they made this observation about something that's really interesting. It's a great opening slide. I don't have a formula to tell you how to do that, but I do believe that in a lot of business plans, there is this inspired business plan possibility, and at least give us a workmanlike business plan, but if you can come up with the inspired business plan that ties things together, I strongly urge you to do it and spend the time to do it, because when it happens, it really is a great thing to do. I want to talk a little bit about investing. So what makes, and I'll talk a little bit about the Affordable Care Act, but law degree notwithstanding, again, I think ACA means Angel Capital Association, so I'll leave the real deep insights to you. In any event, who knows what's going to happen? It's all a crapshoot. So, what makes a good investment? Well, a good investment, I guess they'll tell you in business school, a product which will work, which you can bring to a large market, that can attract sufficient funding for development and commercialization. It's well differentiated from its competitors, and it provides an opportunity for investor liquidity and a strong return in a reasonable time. So, as we look at these criteria, what do we think about how they apply to the life science business? Well, I think none of this applies to the life science business. So why do we invest in life science companies? And that reminds me of a statement of something from Woody Allen, which is Woody Allen sitting in the psychiatrist's office, and he says, maybe some of you've heard this, he says to the psychiatrist, "Doc, my brother, he thinks he's a chicken." And the doctor says, "Well, why don't you turn him in? Have him committed." And he says, "Well, I need the eggs." And that's why we invest in the life science business, because we all need the eggs. We need this industry. It's incredibly important to us. It is what motivates our spirits. It's what motivates our souls. I talk to entrepreneurs in life science, and in more than any other industry, people are committed. I don't get many people who say, I really want to build a great uninterruptible power supply. But in healthcare, I get tons of people who say, I've got a brother with ALS, or I've got a son with cystic fibrosis. You hear this over and over again, and it's the sort of thing that motivates us. And there can be great returns. And I think, we've heard from some of the people in the room who've had amazingly good careers in this business. It can be a great industry, and it can be a good industry. And that's why we do it. We do it for the eggs that we all may get. So in concluding, I just want to talk for a couple of minutes about how I think about investments in the angel field, and then I'll give you a thought or two about the ACA and what it might mean for investments, but I don't think it's going to be too different from the observations you've heard from the two very distinguished panelists who preceded me. First, you submit a business plan to us, a PowerPoint deck. Often it's a good idea to talk to somebody in the group before you submit, because that way you can get a calibration, you can get some feedback, you can get somebody who knows who you are and what you do, so that it goes into a big anonymous screening committee. You've at least got an advocate. And you should be sure that you think about a bunch of stuff that most business plans don't think about. Have any of you ever seen the movie Memento? A few of you have seen it. I think it's a marvelous movie. If you haven't seen it and you think you might see it, plug your ears, because I'm going to spoil it for you right now. Memento is a movie which takes place with a guy who has no memory, and it takes place backwards. And what I think Memento says about the life science business is you should be thinking about your business plan backwards almost. You should be writing your business plan as if you are telling what happened to your business. That's how well you should know what you're doing. You should know, when I ask you the question, well, so let me get this straight. You've got a product that means a podiatrist can do what a clinical oncologist used to do. And when I ask you, so what will that mean to the clinical oncologist, and how will he think about your product, you'll be able to answer it. You'll be able to tell me what's in it for the clinical oncologist, or how you're going to be able to prove that no matter what the clinical oncologist says, the podiatrist will be able to do this. When I ask you how it's reimbursed, you will tell me how it's reimbursed, And please, if you can avoid it, don't tell me we'll come up with a code, we will get one, because now you've added 2 years of time and $1 million and your burn rate goes on and on. I mean, these aren't things I want to hear. Don't tell me you've got a class 1 device if you don't know the regulatory profile at all. All of these things, thinking about as if you've already got your business in your hand and you've just you're writing the case study of what happened. That's what we like to see. Another couple of words about things that really matter. We really like people to have thought through the clinical trial side. Clinical trials can get really, really expensive. And if you don't know how you're going to prove what you're doing early and prove it in a way that is going to be sustainable, that's a really difficult proposition for us, because very quickly we're going to be hitting on the clinical trials. We'll look like sharks, in the water. We'll look for the weak spots. We'll look for the blood, and that's what every question we'll be asking you will be about those sorts of things. Intellectual property is a really important area for us. In fact, excuse me, in the last several deals that we've looked at, a number of them have failed because we have found gaps in intellectual property. So pay attention to intellectual property. Figure out how the conflict between the different professions will work. Figure out how you're going to prove what you're doing. The conflict between professions is very real, because each specialty, believe it or not, even a cancer doc wants to be paid. They want to cure cancer, but they want to be paid. And there are a lot of infusion clinics and cancer docs who are selling drugs because they like, I'm not saying that's the only reason, but that is a factor that has to be considered. So follow the money, like Willie Sutton said. And really give some thought early to how you prove what it is you're doing. The last thing we want, and it happens from time to time, is someone comes to us with a great idea, but they have not a scintilla of proof of it, not even a whiff of suggestion of why it'll work, but a whole series of experiments that they want to do, and at the end of those experiments, we'll know they work. Those are science projects. Those are not investments for us. So, Affordable Care Act and where this is all going, I think you've kind of heard the drill. Healthcare is getting more and more expensive. In the old days, maybe you could come up with a slightly better device for a lot more money. We don't want a slightly better device for a lot more money. We don't want you to tell us you'll save 5 minutes in the surgical procedure. We want you to slash costs. We want you to cut time. Those are the sorts of things we do on the drug side, and we do invest in pharmaceuticals and biologics. On the drug side, maybe we'd be interested in seeing some things that are revolutionary, of course, because we don't worry so much about cost on that side. But for devices and procedures and services and things like that, slash and cut, that's what we want to see. I thank you. If any of you have business ideas that you want to discuss, my email is somewhere, but not up there. I'd be happy to give it to you after, and thank you for your time.
Thank you, Richard. So now we want to go to the question and answers, and could the panelists please come up? Richard, they say there's a lot of money out there looking for some place to go. And to that I say, give me a call. No, that's true. There's a lot of opportunities out there. So as I mentioned, I will have a couple of questions to throw out to the panelists, but I really would like to hear from the audience. So let me start off, and maybe for each one of you can give us a brief comment on this one. And Richard, you kind of touched on this, but what lessons from the past do you think will be important to remember as we move forward with healthcare reform? And let's start and move that way.
Well, yeah, the lesson from the past is that, well, first of all, the past always repeats itself. Or Mark Twain supposedly said, but some say he didn't say, that history doesn't repeat itself, but it rhymes. And, whatever, we know there are going to be fights, we know there are going to be issues, we know there are going to be cost pressures, we know there's going to be change, but we also know that people want to get better, and we know that people want to be well, and things that further that goal and really further that goal, that's a winner. Another 10 days of, progression-free, of lack of tumor growth, which doesn't translate to survival, not so significant. Couple more years of life, pretty significant. I guess that's the lesson I take.
Hi, Kristen.
I guess the lessons that I think about the most, and maybe this is just a function of the areas that I study, are the importance of organizational change and figuring out how to make it happen, and the importance of financial incentives. And part of my interest comes from when I sort of first started in this business or in this area of study. It was a time of tremendous consolidation within the healthcare industry in the 1990s. For example, and everyone was sure that it was the era of primary care and the era of integration, and everything fell apart. And now we're back to the same sort of stage where everyone's sure that we're going to be expanding primary care, and we're going to find new ways to integrate. And I think it may actually happen this time, but it's clear that everyone understands that there are going to be a lot of challenges along the way. And so I think history is important for learning some lessons.
I grew up in Barre, Vermont in the early 60s and really vividly remember going to our primary care doctor. Before, Blue Cross and Blue Shield was a new thing that we had at the time. And so now, fast forward, and we've created this beast called supplier-induced demand by the way we ran healthcare insurance coverage and the way we incentivized providers to just do more. More volume equals more compensation. So we're changing, as I said, on a dime. And the danger that we'll face now is that we'll have people who will try to jigger their panels so that they're only taking care of well people, because if you're in a capitated environment, then that's how you win. So we really just need to pay attention to how we set incentives. I think, Kristen, that there's a lot of opportunity to do it better now. We have better systems. Since we went through one phase of capitation and failed miserably, we learned some lessons from that. Just for instance, at our organization, we're now creating our incentives. We're taking risk as an organization, not as an individual practice, and we're creating incentives from the top down to change behavior of providers, irrespective of things like CPT codes and payments, but change provider behavior and incentivize patients to be part of it as well, so that we can hopefully achieve higher quality care at lower cost.
Okay, very good, thank you. Any questions from the audience?
So on the end, all of us have a cell phone in our pocket. How are we going to change the investment world, given that we have come to expect certain things from this and say, why can't we be using this with our healthcare?
Mobile is a game changer in healthcare, no question about it. And the reason it is because that little computer that you held up, which is always on and always connected, enables so many things to happen that we only ever dreamed of 20 years ago. One of them is I can get you in the moment when you need it the most. I can reach you in a moment's notice. Another is that when you carry that thing around, you leave little electronic breadcrumbs everywhere you go, and we can package all those up and analyze them and really create a unique profile of you and your activities and feed you health-related behavior information on top of that. And of course, the last is that it can be a conduit for information. I talked about sensors. Sensor data can go through that mobile phone as well. So it is a game changer. The industry right now, it's really interesting, is literally problematic for two reasons. This din of hype is making everyone confused, and there's 1,000 apps for everything, and none of them are very interesting. So it's a reader beware problem right now. That doesn't mean that mobile isn't a game changer. It absolutely is. It's just that it's gotten to the point where people they're doing stupid things because they think they can get rich quick. So lots of attention paid to, does it make sense? It's not unlike the internet bubble of the early part of the century when it was, underwear.com or what have you. Does it make sense? And a lot of the apps don't really. Will it change behavior? Those kinds of questions you have to ask, I think. But definitely has enormous potential to change the way healthcare is delivered and the way you interact with your healthcare system.
I lost a lot of money in underwear.com, actually.
Along with the newspapers, right?
Yeah. I wish you wouldn't remind me of. before I answer that question directly, and Marty, I know that that's a bit of a setup. You should actually probably be answering that question in place of me, but I'll give it a shot in a second. When I sold my company to LexisNexis, I remember LexisNexis, for those of you who don't know, is an enormous online database, huge repository of information. And in the 1980s, it was even more remarkable. Before the internet, before databases like that existed, they existed. And I remember going there and seeing the main computer room, which was a huge computer facility, and talking to them about, this is the room where the data's housed. And they said to me, they said, this is it. And I said, really? And we're a room, probably probably about the size of this room, air conditioners and, the raised floor and the drop ceiling and all that stuff. And I said, and how much data is in those computers? And they said, 2.5 terabytes. That would be something like 2 or 3 of these. And it would cost something like $400 or $300 to buy that. And I think, that's the computer business. And what is the healthcare business? It's given us $1 million Da Vinci robot. What is wrong with this picture? And the healthcare business is not like other businesses. We don't have the same sorts of ability to innovate. And I think that for better or for worse, it's because of the regulatory framework. It's because of the reimbursement framework. It's because of the natural and probably valuable conservatism of the practitioners who don't want to try new things on patients. But whatever the reasons, and there are many, the business just doesn't change that fast. So in a way to answer your question, I mean, sure, this is incredibly significant stuff, but I don't think it's going to happen sort of like blown from Zeus's brow. We're not going to have another Facebook at this. It's going to have to be backdoor insurrections. It's going to have to be things that fit into existing procedures and don't completely destroy them and then sort of co-opt them from the side. That's, I think, where the opportunities are. It's not revolutionary change, I don't think. I think it's sort of very smart side steps that, like the innovator's dilemma, enable you to make bigger and bigger steps from those. I don't know what the specifics are, although you know that we're looking at a couple of them right now as deals. But I think that's the characteristic of what they'd be like.
And just to echo and emphasize, which has been said several times this evening, anything you can do to make the process more efficient. And if it happens to involve mobile, that's okay. There are several companies now doing things like patient intake on a tablet. Not particularly sexy, but it's interesting, and you can throw a little ad on the tablet and whatnot, and so there's a business there, probably going to be successful at some level. Or having the ability for a doctor to display an X-ray or an EKG on a tablet. Again, not earth-shattering. It's not the kind of innovation that we're longing for, but those companies will be successful because, again, they're chipping at the edges of making processes more efficient.
Thanks. My question is for Ms. Madison. I don't know if this is an appropriate question, but I just had a question about the employer-offered insurance. Because I noticed there was like a 10% decrease over like 10 years of employers decreasing their insurance offering. Do we know why that is? And like, has anybody addressed the fact of like, if we have Medicare that's 17 and employer that's 4, why are we not looking at why employers stopped offering insurance? And what can we do to entice them to offer insurance to then lessen the burden on Medicare increasing? I'm just curious if that's like, I don't know if that's an appropriate question for this topic, but I don't know like if anybody's, I'm assuming they have, and I just don't know.
I mean, I think it partly has to do with the economics of it. I mean, a lot of that period we were, especially in the latter part of the period, we were in recession, right? So employers are looking for a way to cut costs, and healthcare is costly. So that's one of the reasons why you see employers getting out of the business. There are a lot of employers that don't want to be in the healthcare business, and so that is part of what's happening. And the interesting thing about your question is sort of a presumption that the employer-provided health insurance is the right way to go, that is the ideal. It's certainly true that since mid-century, mid of the last century, it has been the way that we have gone as a country, but it's not obvious that that's the best way to go. And I think sort of this is what some health policy thinkers are thinking about. So some predictions are that the Affordable Care Act, if it actually gets implemented, will lead a lot more employers to drop insurance in favor of pushing people to the exchanges. And there's differences in opinion of whether that's a good thing, because on the one hand, employers have helped a lot of people get insurance and sort of manage the process. On the other hand, the hope is that the exchanges will be configured in such a way that they really will help people get the products that they need. So I think there's a lot of change going on.
I'll make a couple of comments here. I think one of the reasons is that the cost of healthcare has skyrocketed, and that benefit as an employer funded in a majority way has gone up with it. So people have looked at providing it or not providing it. And, you know, I know that in my career, I've seen where people were provided 100% of the premium coverage by the employer. It's down now in healthcare anyway, maybe in the 75% employer, 25% employee, and that trend continues to go. The other fact of the matter is that some of these international companies, when they provide those kind of benefit structures within their company package to employees, they're at a disadvantage on the international scene because international, outside of U.S. Firms, the social net, if you will, in some of these societies picks up the cost of healthcare. So it's made companies not competitive. And I think that's part of the reason also. It's interesting, I read something about if the act goes forward as it has been proposed, that the employer may dump some of the coverage and take the penalty. And I think the Massachusetts experience was exactly that. The penalty you paid for not providing insurance for an employee was less than the cost of providing it. So one of the first things they said, wait a minute, everybody's dropping insurance here on everybody. So they had to push the penalty up to keep people in place like that. But, you know, and some of the other provisions that have already taken place, whether it's ensuring, allowing dependents to stay on insurance till 26, some of the pre-existing type things, some of the colonoscopy screen, things of that nature that have already in place have just pushed that price up without any corresponding return for the employers. So you'll see, in my opinion, if it goes forward the way it is, with the mandate, that employer plans, especially some of these sexy kind of premium packages for executives with all kinds of different features that are not taxable and not tax deductible, I think you'll see them start to winnow down to more stratified, standard packages. You may see dental care and vision care fall out of those just because it becomes a numbers game and they've got to do it anyway or they're going to pay a penalty.
We had, Google and Microsoft with Health Vault and Google and tried to create some kind of repository for people to keep their health information. With all these systems coming online, Exchange has been used as a marketplace, but as far as I'm concerned, the actual data exchange of information from one health providing entity to another, how do you see the exchange of data be improved over time, and who is actually going to hold on and kind of be the repository for that data?
Joe, that's got you written all over.
Yeah, some people are looking at me. I'm the oracle here. Good question. No, I think a couple things. One is you hit on a couple of them. I just want to emphasize a couple of points you made so people can digest them. One is, which isn't your question, but I still want to pick up on it. That is the death of Google Health, which was totally predictable, because if you just throw something out there for people to put information in but don't give them any real reason to store it, people are busy. Why would I, right? That was what everyone said. Well, why would I? Doesn't my doctor know that stuff? So no good use case, no good model, and just because they built it doesn't mean they'll come. Most of the things Google builds, people come to. That one they didn't. So now to your question. We have to get to the point where I'll just give you our example. We're here in town. We're friendly with our competitors here in town. Healthcare is a pretty friendly environment, but we don't share data readily with them. Don't have a real reason to it. It requires, interfaces. They cost money. It requires building pipes. Nothing's standardized. if we look at our capital requirements, why would we spend, and I'm not trying to pick on Beth Israel Leahy, but why would we spend money to build pipes into their organization? There's no incentive. So we have to get to the point where we are, and maybe the Health Information Exchange will help with that. Maybe the High-Tech Act and standardization of things will help. We'll see. But it won't be because we sat around and said that's really economically good for us.
So you don't have any incentives just yet?
Not at all.
I mean, there's some activity in that area, right? There are regional. You talked about a bunch of different kinds of information sharing, and so I think the issues are different for each one. There are certainly regional organizations that are springing up all over the country where they're exchanging, providers are exchanging data with each other, but they're not fully interconnected yet. There's regulatory issues that are being discussed right now at the federal level about how that might work. On the exchange side, I mean, simple things like how do we fully apply IT to Medicaid enrollment. So many states are still doing paper enrollment, or you can go online and fill in a form and then they print it out and key it in. I mean, this is crazy stuff, and we're still not even to that point yet. So I think there's a lot of work to do in a lot of different dimensions in all the areas that you talk about.
You can look at it sort of phenomenologically too, just sort of the trend of it. It's kind of like a Federal Express problem. It's really hard to start Federal Express and go from Boston to Pittsburgh. You got to start Federal Express and go between hundreds of cities. And so if you're going to set this up, I remember in the 1990s, there was a game I used to play with people, a strategic game. I'd say, Microsoft, I know that nothing lasts forever, but what in the world will stop Microsoft? And the things that did stop it were not so predictable. The rise of a rival operating system under Apple and the internet thinking of the web as an operating system, those things weren't predictable, and yet those are sort of what kneecapped Microsoft and hobbled it. And there will be things, eventually this is too important not to happen, but in the short run, it's going to be lots of little clusters. You're going to get, a doctor who puts a system in and a hospital that puts their own system in. And at some point, something will come along that will be easy enough, and there will be enough infrastructure there that it'll just sweep and go everywhere. I don't know when that'll happen, but it's going to happen at some point, and it'll happen really quickly at some point.
I mean, the good news is we now have standard ways of presenting things like medication list, allergies, an office note. So that's the other way this could happen. If it's our system, I'm again using us as an example, creates these information renderings anyway, and if we know that our patient is in the emergency room at system down the road, and it's of no extra cost to us to share that, we'll share it. Again, we want the patients to do well. That's part of the reason we're in business. But if it requires the sort of old-fashioned IT solution, all this was build an interface, and that's several $100,000, and that won't work.
And it's regulated often.
So my sense is that entrepreneurship in medtech is really in crisis. VCs aren't investing in medtech. SBIRs are more competitive, and budgets are declining. Like you said, people want to know what the last frames of the movie are before they're going to invest. So you almost need to have the research, have a quality system, have a KOL validation, and all of the data in place, and a regulatory pathway and reimbursement. You have all that stuff figured out, and by the way, there's no money to do it anymore. And so I guess I'm looking at you and wondering, do you see kind of some positive light at the end of the tunnel? Like how is this going to evolve to a better place? Because right now it doesn't seem like it's a good place to be.
It's interesting. I just was looking recently at the National Venture Capital Association statistics, and in biotech, they're actually not so bad. Even in medtech, they're not as bad as you might think. The amount of money invested in medtech companies this year, it's not like you're going back to the 1990s to get to similar levels. It's like you're going back to 2004, 2005. And then there were some pretty frothy years there, so I don't know, maybe you want to say that the frothy years are the norm, or maybe you'd settle for 2004, 2005. Nevertheless, there are a lot of VCs leaving the industry. And some of the investment of 2006, 7, 8 were sort of maybe the dying throes of VCs trying to invest into things into funds that they hoped might lead to future funds. The good news is that there's a bunch of angel investing in medtech, and to some extent the paradigm is changing. I'll talk very quickly about that. One of the no-nos in a business plan that I see is when somebody says, we always want people to tell us about the exit. The exit for us is how we make our money. The exit for us is not necessarily the exit for the entrepreneur that means they're going to go into the market. It's how we get our money. The things we don't want to hear, we certainly don't want to hear that you're going to go IPO, because you're not. And you know, if you say that, it just means you don't really understand the market. So don't say you're going to go IPO. We don't really want to hear that you're going to go to market, although I'm interested. There are a couple of companies here, and often more in the IT side of space, that actually are going to market, but that takes a lot of money in medtech. We want to hear that you're going to exit your company. And we had an exit. We had an 8-month exit on a device that once they got their 510(k) approval, it was a very fast path to an exit. If you can paint a story about a convincing reason why you will be a good bolt-on or fit into someone else's portfolio, we'll listen to that story. We'll give you money in the early stage for that story. So one of the things that it really helps to be as an entrepreneur is immensely persistent, and I'm not saying that it's easy. I think you've over-characterized when you say you need to do all of these things. We don't need all of it. We need suggestions of some of it. We need be further along for some of it, perhaps. We don't need all of it, but we need to know that you're the person who can make all of it happen, that you're persistent. Sometimes the fact that you've been at it for 2 years is the sign of persistence. Not a good thing for you, but sort of a good thing for us, because not everyone does that. It's difficult. I really think it's very difficult, but it is not impossible, not by a long shot, and maybe that's a good thing.
My question is actually directed to Joe, because I'm a patient at Partners, and I used to get an annual physical. Maybe 10 years ago, I was in my doctor's office for half an hour. Now I'm in there 10 minutes, and out of those 10 minutes, 5 minutes taken to take my pants down so I can do whatever. My question really is that the clinician is sitting in front of the computer, he knows everything about me for the last 30 years. Now, how long can we continue to feed in information to our computers and store it and get it back within minutes and seconds? Will that technology expand so that will be available instantaneously as we wish it to be? I know I sit in front of my computer and sometimes it takes 5 minutes to download a particular website. Now, will the technology for combining Mass General and the Deaconess and all this become available so that that is all stored at one site?
In a word, yes. And I think what you see now in healthcare information technology is a glimmer of what we can do. I would just remind you how much, I don't know if you use Google. I'm assuming you search on Google. They know a tremendous amount about you by the searches you do, and they know it's all you, and they've it stored up. Facebook, Apple, Amazon, all of them know enormous things about us by the way we use their tools. In healthcare, we haven't implemented that yet, and that's not, it's a solved problem. They're all doing it. So the analytics are there. The speed of delivery is there. The computing, of course, is now all in the cloud. So I absolutely think we can get there. Again, we need incentives to do that as an industry that we haven't had yet. We're just getting to that point, and they're coming fast. So I'm quite optimistic. Now, the problem that I thought you were going to ask me about, which is the fact that you only get 10 minutes through the doctor. That, again, I said that in the beginning. That's a symptom of the fact that we insist that you do everything in that 10 minutes. We can do better at that too by giving you opportunities to care for yourself and giving your providers opportunities to care for you when you're not in that space. And you feel better cared for, and you'll use that 10 minutes more wisely.
We almost invested in a company that drops your pants in 2 seconds. Because it would give a 4-minute and 58-second additional chance for your checkup. But they didn't have a good raise the pants back up solution. So.
Richard, maybe you go back to underwear.com. Maybe.
Yeah, right.
No, I just, a little anecdotal thing. Last time I went to my doctor as I was leaving, he said, oh, hey, by the way, here's instructions how you can get access to your whole medical record online. I encourage you to do so. That's pretty refreshing, because I've always had to ask, can I have a copy of that? You know, so I mean, and it goes back to what Joe was saying. You need to empower the patient. And if you feel like, you know, they're putting data entry in and giving you nothing back, that's not reform, really. Any other questions?
I have a question, and maybe we need to explain it afterwards. Is what we read about at any time soon, let's say in the next 10 years, a stock on the market like Apple, but it's a health provider network. In other words, will some small startup invent a new provider system that's for profit? Because traditionally, our providers have been split between the hospital system and the docs. And the docs are for profit. So we're trying to solve the problems of the world with a not-for-profit system. Will there be an Apple in our future that's healthcare related?
My opinion is yes, although I don't, you know, to echo something Richard said earlier, it probably won't look like what you think now of as a provider system. I would counter by saying one of the problems we face in innovation in healthcare, and it's a really fundamental one, I've thought a lot about this, we have this role in healthcare called the doctor. And if you are one, you kind of know what that is. But if you're not, it's this mystical thing. And every healthcare organization has at least one. And they're pretty pivotal in decision making. So right now, our healthcare system in this country, and I'm happy to be able to put my kids through school as a result, it's designed to make doctors do well. Why would we want to change any of that? So, and that's a problem. That's a problem when you start to talk about cutting costs, and you've got to ask the doctor for permission to do anything innovative. So my reason I bring that up is because I'm looking for exactly what you described. That is to say, I think it's going to be something like the retail clinic. That's a good example, right? They took away 5% of primary care and no one seemed to notice. Life's going on, primary care docs are busy and they're giving you 10 minutes anyway. But someone comes in and takes a solid chunk, and maybe it's because it's some regular thing that we all do, we all have to do. We have to go in, park, wait 2 hours, sit in a cold room and get it done, and we're all annoyed and don't realize it, and all of a sudden you can do it quickly online and get higher quality. Probably not from a doctor. That's probably what I see is going to happen. That's just my guess. And then all of a sudden, we will, you know, we as a healthcare provider organization system will wake up and say, oh, we could be disrupted. Right now, we don't think we can be disrupted.
Well, thank you very much for such an informative set of presentations and a very stimulating panel discussion. One of the things that is great about being in a university is the spirit of innovation and experimentation that goes on all the time. I think a lot of faculty get that. But for the benefit of the students in the room, I'm wondering if you could just comment on one thing that has been important to you in your own professional development that got you thinking about entrepreneurship that we might be able to think about here and introduce into our curriculum.
Want to think about that?
Well, I mean, I have one answer, but it's not really my final answer. But
this is Jeopardy, right? Final answer.
Well, I mean, the thing that got me into entrepreneurship is I didn't want to work anywhere for anyone else. I mean, I don't know what that's not. I don't think what you're looking for, and I don't know how you teach that. And I mean, there are people who want to do that and people who don't. I'm a crummy employee, so you know, what choice did I have?
I've got a question. I mean, Kristen mentioned earlier that with the ACA, there'll be 30 million more people that are insured looking for services, but there'll be no corresponding increase in the providers. And you can only look to Massachusetts to see how that worked. I don't know if you've had this experience that I've had, but you don't want to go to an emergency room in Massachusetts right now because a third or more of the people are not there for emergent care. And if you are trying to get a new primary care physician and get an appointment, good luck to you, because there's not enough around. So having said that, and I know we have a couple of nurses in the room here, I can just see it. What can you comment about, and maybe there's a legal issue here too, Kristen, about the expansion of the nursing role, nurse practitioners and the like, as far as handling the increased demand on the system? And either one of the panelists also.
Well, I'll take I don't want to monopolize the mic here, but I do feel passionate about that. I think that we have to do more of that. We actually, again, the reason I say make the patient their own doctor is because I'm skipping the nurse and the nurse assistant and going right to you. Why don't we make you in charge? So sure, we should have nurses do more. We should have doctors do less. They're high-cost labor. They do way too much.
I'm on the board, actually, of a company that delivers home health care. And I want to first say that I think what we've done in a way to the medical profession, I don't know if we've done it consciously, but it's shameful. I mean, I hear people all the time bemoan the care that they get because the doctor's too busy or the nurses are too busy. We've put everybody in this position. I mean, we haven't deliberately done it, but the system's done it. We've overwhelmed the system. People spend hours trying to get reimbursement, and then we wonder why they don't have a lot of time to deliver care. In order to have something like an Apple computer in the healthcare industry, Apple Computer works because it doesn't require almost any effort to deliver another very expensive widget. You can just roll them off. And until healthcare is delivered by widgets and not so much by people, it'll be really expensive. So we need to push healthcare down and down and down and down so that, you know, yeah, you are being, basically you do have a visit with your smartphone. Someday, I mean, I don't know if people will stand for it, but, you know, that's what the bed talk.
They'll prefer it.
That's what the bedside talk. They'll prefer it because it's that and Angry Birds are their best friends.
No, we put up with so much crap through our system that we don't even appreciate. But if you think about who here has a great experience with the healthcare system, I don't. Well, you might love your provider, but the system sucks.
I think there's a tremendous amount of effort going into thinking about scopes of practice and what it is that nurse practitioners and other kinds of physician extenders might be able to do, but there's extraordinary regulatory challenges and turf battles, quite frankly, in trying to work its way through the process. And that may be one reason why it makes sense to focus on the patient rather than continually having to fight those battles state by state for every single issue that you want to, or every single kind of practice that you want to be able to extend to somebody else.
Yeah, I just want to follow up on those comments, kind of elucidating a little bit. Do you think that there's going to be a market for concierge service that started about 10 years ago? And not just for rich, but I'm just saying, if you are a group of practitioners and you have a fixed group of patients, you're more likely to be able to have the time. And would there be investment for those kinds of things? And I'm not saying just from a physician point of view, but an integrated practice. I'm a pharmacist, so you know those are the kind of things that I would think would be really making solutions to the problems we're talking about, as opposed to this global, ACA type of thing.
One thing that's going on is there's sort of a sub-rosa covert attempt to gut the services that insurance companies give. And they're doing it by, causing extra waiting time. There are tons of things in the process that are designed to undercut conventional care. And people with, so what the effect of that is the insurance that you pay for isn't quite the insurance you think you got. The insurance you think you got isn't the insurance you got, rather. And so as people start to realize that, more and more people are going to want a level of service that they can pay for if they have the disposable cash to pay for it. There aren't that many people as a percentage that can do it, but there are a huge number of people who can. I mean, I think it's a good trend, but as an investable proposition, the difficulty is sort of making the value proposition and showing how you can scale it, because it's probably expensive, and the margins, I don't know if the margins would be great. I mean, if the numbers worked, it's probably pretty investable because you could do it in a very small scale, and then if you could figure out a way to scale it, it might be a very investable proposition, and it certainly makes sense.
I mean, I think there is some market there. I remember talking about this with one of my classes, and I was surprised. It was a class of I think about 14, and I asked how many of them knew what concierge care was, and half of the class had parents who were in practices like that. One of the students was actually there. She was a nurse, and she had had cancer, and she was so sick of navigating the system that she wanted someone on her side. At the same time, we have lots of research showing that if you put a $10 copay on a drug, that it affects people taking it, right? That it affects medication adherence. And so it's hard to reconcile those two things, except to say that there may be different sort of stratas of the population that are affected that may be able to take advantage of that kind of care, and others who can't.
A quick, when we get the microphone over here, I got a quick comment on that. There's a company called MDVIP, which you haven't seen them, look them up. They're actually owned by Procter & Gamble, and that's concierge medicine. A typical practice, I don't know, Joe, you might know, or Richard, or all you might know, goes from like 4,000 patients down to 600. That's all they follow. And then those 600 people pay the physician $1,800 a year to just follow them alone. Quality of life for the doctor, you call the doctor, you get an appointment that day, you go to the hospital, he comes in and sees you at the hospital. Very powerful model. It is somewhat elite medicine, and the government fears it greatly with this going on, with people waiting longer and lack of attention to detail. And go ahead.
Hi, so I'm building off the question that came from my fellow Northeastern Husky about education and entrepreneurship. I'm an undergraduate computer science student, and as I'm finishing my major now, I want to be an entrepreneur. But then again, when you're an entrepreneur, you think that you want to do that when you're young, when you have a lot of energy, when you devote the majority of your life to work. But if I wanted to get into health sciences entrepreneurship, is the education in the medical field a necessity or requirement? Do I need a health informatics degree? Do I need the entrepreneurship program that they were talking about that this program is for? Can you go and can you be effective? Can you invent new apps that promote efficiency in the hospitals or revolutionary technology without knowing the human biology and anatomy?
Different skill set, I think. I guess you have a couple of live examples. Bill Gates and Mark Zuckerberg, both college dropouts that did pretty well for themselves. It's a different skill set. I mean, there's no question understanding biology will help you. Is it a requirement? Absolutely not, in my opinion.
I mean, not having a single degree in healthcare. I'm a big believer in self-taught, and nevertheless, there are a lot of moving parts, and if you're not a devoted student of self-learning, you really should get the degree because it does two things for you. One of it, which is gives you the knowledge, and the other is it gives you the imprimatur, right, so that you can get the job that, or you can go to people and be convincing that you know something. Otherwise, you just have to do it with what you know.
What do you think of the Minute Clinic?
The CVS Minute Clinic?
Well, I'm a big fan myself. I mean, not CVS's product in particular, but retail clinics as a concept, because I'm also a fan of the Clayton Christensen model of innovation. And what retail clinics did was they took a series of very kind of algorithmic decisions that really arguably their nurse practitioners are overqualified to make, and then they put them in this place where it's a new care delivery environment. Walgreens is within like 100 feet of everyone, you know. So all of a sudden you've got this new set of services that are very algorithmic in nature, quick. What mother wants to go to the ER to get a kid's ear infection looked at, right? And they're, no surprise, they're wildly successful. And I think all of them are successful. I just wish we could do more things like that. I think they should expand.
I want to go back to a couple of things that have been said and sort of see if we could reconcile some things that might be in opposition. One hand, Joe, you're talking about how we make the mobile phone or the tablet, you know, the doctor for folks. But on the other hand, you stated that there's no incentive for you to open up, you know, channels for you to exchange data with other hospitals in town. So for the entrepreneur who's looking for the way, the breakthrough application they want to bring out to consumers, how do they get access into the EMRs to be able to actually see what's going on, be able to tie into those systems? Do we, you know, will it evolve that these vendors are opening those up? Is it something that there needs to be legislation? What are the incentives for folks to be there? And what are the cautions that you would share with the people here about sort of staking their venture on dependency upon external systems?
I want to be careful in my not sound flip in my response. I guess I would try to innovate from around and without of the healthcare system. Again, I think it's almost hopeless that we're going to do major innovation within healthcare. And so what can you do at the consumer level that doesn't involve needing an EMR? Think that way. How can I do things in wellness? How can I do things in alternative medicine that simply avoid that problem? That's how, if I was starting a business, that's how I'd think about it.
Yeah, the answer I think on that, the pat answer is that the biggest payer ought to dictate the way they want the information, and that's Medicare. But my experience in dealing with in that instance is a disaster. They can't decide what they want and how they want it. So it's a evolving problem.
I don't know if you can answer my question. We all know that technology has done much to improve the quality of patient care. So I'm wondering, in the near future, is it what will happen? Because technology has been replacing nurses' duty and physician duty. In the near future, is technology in the near future is gonna be enough job for people because technology will replace nurses' duty and physician duties. What will happen in the near future?
No, I'm so glad you asked. So my thought on that, and I mentioned this when I was at the podium, we have a long ways to go. We're oversaturating our provider workforce so badly now that we could either cut the demand in half or double the supply and not notice a difference. So plenty of opportunities to take jobs away from human beings and have those people real busy for probably the rest of my life anyway.
Okay, that's pretty good stuff. I think we could go on for a while, but Julie would never let me do that. I'm going to invite up Carl LaBelle, who's the Chief Scientific Officer for Autonomy and a health science entrepreneur, steering committee member, and one of our key people. He's going to summarize. Oh, I'm sorry, the panel can be released.
Thanks, Chris, and thanks to the panelists. Great program. So I am an '89 graduate of Northeastern. I spent the better part of 5 years in 312 Mugar Hall. And did I think when I was in Mugar Hall that I would find myself knitting the last 2 hours of this program together? Of course I did, right? And when I was in Mugar Hall, did I think that I would actually be quoted in the current issue of Vital Signs that will soon come out? Yes, because my advisor is retiring, that's why. So, okay, I'm going to just focus on 4 topics. And the first is common threads of the speakers. And we asked everybody to sort of look backward to about 2000 or so and talk about today, and then talk a little bit about the future and what they might anticipate. So there were some differences in what the speakers talked about. Kristen said, you know, healthcare reform has been happening for a while. And regardless of what happens at the Supremes, it's going to keep happening, right? So kind of status quo, if you will, but it feels like a lot of change right now. It feels pretty volatile, right? But it's going to continue. Now, Joe talked about really, I think, a big change, and he mentioned that relationship between the doctor and the patient. If that changes, then there's a huge value add to the system, right? That's a sea change right there. And as I was listening to that, I was thinking about if you're in the drug development business, you're trying to get an assessment of disease today, and whatever disease your company is going after. And you're trying to characterize what the management of that particular disease is, how the healthcare system works for those patients. When those patients then come into a clinical trial, everything's changed. There's a lot of intervention. We equip them with PDAs. We ask them to enter their diaries. They're visiting their clinics and the participating sites quite frequently. All that care is given to them at no cost. So how we characterize the disease today in the real world suddenly changes quickly when we start doing clinical trials. So I was fascinated by that and wondering whether that there might be a domino effect from the business model you're talking about back into the drug development space with respect to clinical trials. So I found that fascinating. And after Richard walked us through his enlightening past, I was struck by the fact that you focused really on a number of foundations that really don't change when you're looking at an opportunity to invest in. And you talked about different approaches to business plans. One of them is the more complex that by slide 8 you've checked out. One of them has everything in it, and it takes several hours to get to the end, and the other is the inspirational one. And in my experience, we were able to raise a nice round of financing a couple years ago, and we're in the ear space. And our opening slide was, "We stick it in your ear." So I think that was inspirational, and that led to a successful financing for us. So those are the common threads for the speakers, and we asked them to structure their discussions that way for the program. Now, the next one was really about the disposition of ACA and what might happen if it fails or if it's changed. And I think the sense was the bottom is not going to fall out of the healthcare system, right? There may be changes, there may be not, but there's really not going to be a huge wave that's felt more than likely by the industry. So a number of potential consequences could occur. There was mention of perhaps employer-sponsored programs moving towards exchanges. I think Chris mentioned perhaps more standardization of healthcare packages, maybe a pull-down menu, those sorts of things. So I think that was interesting to listen to perspectives there, especially at a time today where we are saturated in the news by the tragedy that could occur based on the decision that comes out of the Supreme Court, right? So I think we can all rest a little bit. The next part that we talked about was technology, a lot of discussions around technology. And Joe actually used the expression game changer, but then we quickly sort of pivoted into discussions that really had a tone of, we're not really though sure how to use technology when it comes down to healthcare management. A lot of uncertainties. There's perhaps some successes in elite programs, but we have a lot of challenges, and one of the larger challenges that I heard was the positioning of the doc in the healthcare system as being the point of inertia, if you will. And everyone is having to work against that inertia. Docs love where they are and what they're doing and aren't perhaps all that interested in changing. And everyone that is in or around the system looking for opportunity is trying to figure out a way how to get this thing changed. and create value and opportunity for everyone. So I thought that was spot on and a really interesting topic that a lot of people pointed to. So the last element is really to that same point, inertia, that we've created it. And you know, what can we do? Is it incremental, that each of us does our part? Is it taking a model like an elite program that works really well and perhaps building out from that? It sounded as though we're not quite sure yet, but in every one of those points, some of them were presented as issues and challenges, and every one of them is opportunities, right? Every single one of them. So I hope that I've been able to knit everything together for you nicely. I'm sure I overlooked a number of key messages, but that should give you a pretty good takeaway from tonight's program. Okay, thank you. Chris.
Just a couple of quick closing comments. Pretty good stuff. It's a very heady topic. You know, even though we heard from Kristen what happens if this doesn't get through the Supreme Court or whatnot, but there's a lot of things that are already on the road that are going to go forward no matter what the Supreme Court does. I mean, whether the primary care physician will become the center of the universe, and rightfully so should be. There's alternative ways to deliver care. Information technology can lower costs and improve the patient taking on their own responsibility. There's a lot of stuff like that I hope you heard here tonight that you can take forward and say, this is the way the direction of healthcare is going to go, no matter what happens. So I hope it was helpful for you. I just want to have a couple of quick thank yous. First and foremost, to our outstanding panelists. I thought they're a great group. I say we give them a good round of applause. Where I am. Secondly, for Julie. Where's Julie? Oh, right here. Stand up, Julie. You know, Julie is the chief architect and coordinator of this event. And to say that Julie keeps the trains running on time is really not saying it all. She not only keeps them running on time, she cleans the station, she drives the train itself, and she takes the heat when things are not on time. So a round of applause for Julie, please. And also, I'd like to give thanks to Dean Terry Fulmer, who's not here tonight, but who, since she's become the new Dean of Bouvet, has been very wonderfully supportive of our program and is a real visionary in her own right. And I remember having a conversation with her, and if you look at the portfolio of Bouvet, between nursing, pharmacy, physical therapy, all the other health sciences, it's a great package to put together, you know, new ways of doing things in the healthcare reform. So we're real excited about the dean and her spirit that she brings, and she's nationally recognized, and she's really a terrific person. But finally, I just want to thank the audience, because I thought it was a good group, a lot of good questions. I wish we could have gone longer, but Julie writes the rules and sets the train schedule, so that's what we're living on here. But you know, at Health Sciences Entrepreneurs, you know, we believe there's an entrepreneur inside of everybody, and our role is to try to help you get it out of there. Everybody has an idea. Everybody, as Richard, doesn't want to work for somebody else. You might have to work for a while for somebody else, but and if we can help you, we're here to help you. So thank you again. We hope you enjoyed everything.